Alan Greenberg. I know most of you in the room and really grateful you all took your valuable time to come. And I'm the director of the District of Columbia Center for AIDS Research. Fred was my colleague, my boss, my mentor, and my friend. A year ago, many of us convened at the Veterans Hospital, with Ginny led and Deborah led an important session just after Fred had passed away. In my eulogy, I promised Fred's family that just as they could never forget him, neither could we as his professional family. Thus, we gathered today, 1 year later, to pay tribute to Fred's scientific career, to celebrate all that he contributed to science, and to pass the torch to the next generation of clinical scientists in Washington, D.C. I'd like to thank Anne and the family for their support. You'll be meeting them today. Just a show of hands, Fred's family members, if you could raise your hands. So we have an incredible turnout from his family and his colleagues from the VA, present and past. It's really an amazing group that's assembled. I also want to thank our staff. Putting these events together is quite complicated. We're WebExing, I think, around the world. Fred's colleagues from, I think, Uganda are on the phone, and people far and wide from his networks. So here's our agenda. After some brief welcomes from several of Fred's closest colleagues here, we're going to welcome Dick Chassan for the Fred Gordin Memorial Lecture. And thank you, Dick, for coming here. And then we're going to honor the legacy of Fred Gordin. Anne, his wife, will come up and we'll say some words. And then Princey Kumar, Fred's successor, is the director of the clinical core. A little space for Mary Young in between. Mary, thank you for coming today. We'll be presenting the Fred Gordin Clinical Investigator Award to Dr. Sebly Kasai, who's PI of the WISE at Georgetown. She's here somewhere there. And then Sebly will be giving a talk about her work as well to hopefully show Fred his legacy is in excellent hands. And then 11 o'clock we'll adjourn. So I just wanted to let you know who's in the room today. I always show the slide when we have our citywide events. I'll let you see it, but it's really an incredible turnout from many, many organizations. So with that, I'm going to pass it on to our DCC FAR co-director, Gary Simon, and he'll pass it to Ginny Kahn.
Good morning. I'm going to give you some personal thoughts about Fred as well as some academic issues. I want to welcome everybody, thank them for coming. I especially want to welcome Fred's family, and especially to Anne and Dana and Jonathan. He was intensely proud of his family, despite the fact that Jonathan's a cardiologist. he bore that cross. Fred trained in San Francisco, and at was sort of the height of the HIV epidemic, and his career was, I don't want to say exclusively, it was not. It was primarily, but certainly not exclusively related to HIV infection and its complications. And Fred actually saw what was a virtually universally fatal disease become a treatable chronic disease. And it's been a striking transformation. And Fred and I often talked about how things changed over the decades. Fred liked big questions. We talked about this a lot. You know, sometimes you do little small studies, one-off studies, especially for the fellows. Fred liked big questions. And among his two studies was the study that told us, no, we shouldn't stop medication in anybody, and we shouldn't wait to start medications. And those are striking studies, and they've really changed the whole way we approached the treatment of HIV infection. So anyway, that was Fred's approach to HIV infection, and that is to answer the big questions, and he did. 15 years ago, Fred and I met, and we decided to merge the two divisions of infectious diseases, GW and the VA. And it was a great marriage. A lot of good things came from it. First, the fellows had many more opportunities to do research projects with many different people, many different views of attendings, because none of us ever agree on how to treat a patient. So we had, and the fellows got to experience these differences, which are very valuable. The marriage worked out to such a great extent. Anyway, it was a great time together. We set up a joint conference, the CASE conference, and quite frankly, the CASE conference was the best part of the whole fellowship. Many applicants who came and many fellow applicants came in, and they told us what a great CASE conference it was. It was done with a little bit of humor, but that was the best CASE conference of any program they had visited. I think that one of the highlights of our merger, our marriage. So Fred and I commiserated together a lot, actually. Frequently at the CASE conference, we sort of adjourned to his office. And I know that you all think the VA and GW are absolute paradise, but sometimes things weren't going perfectly. And so we had the opportunity to commiserate. We commiserated about a fellow who wasn't quite what we thought they would develop into, minor little faculty issues, funding, dealing with administration. But it was very comfortable to have somebody who saw the same problems and that I could sit down and we could talk about it and deal with it. So to close, Fred wasn't really a colleague. He was really a friend of mine, and I miss him. Thank you.
I'm Virginia Kahn, and welcome to everyone here in this room and on WebEx, to his family, friends, and colleagues. It is with great gratitude that I really express on behalf of the VA thanks to Alan and Gary for holding this event to honor Fred in this meaningful way. And in addition, I want to give a shout out to Patty Simon and Aaliyah Murphy for making this happen. So as you all know, Fred had a wonderful career of 34 years within the VA Medical Center here in Washington, D.C. And he leaves a rich legacy as teacher, physician, and researcher. As a teacher, Fred obviously gave wonderful mentorship and guidance to fellows and educated them about the art and science of infectious diseases. But more importantly, he shared in a great way and a practical way that it was good and beneficial to have fun. So for my coworkers here, you probably remember that he exalted everyone's talents in baking and costume making for the many bake-offs and parties that we had at the VA. As a physician, he deeply cared for his patients. And as some of you who are my age and perhaps a little bit older know, back in the 80s when Fred arrived at the VA, sadly there were very few patients in his clinic, but he wanted to create a safe and warm haven for medical care for persons living with HIV. And so he actually was the first to integrate care, to make co-located services from other subspecialties and mental health providers to give our patients the help and resources that they needed. So he realized, perhaps 20 years ahead of his time, a truly patient-centered care environment. And lastly, Fred was obviously a talented researcher in both HIV and tuberculosis. And towards that end, he wanted to make sure that the community was engaged. First, by making community centers, such as the VA, part of large clinical trials. And that was the formation with Wafa El-Sadar and Bopper Deaton, the community programs for clinical research on AIDS. He worked with Jim Neaton Ab Abakar and Jens Lundgren to create the International Network for Strategic Initiatives in Global HIV Trials, which is the Insight Network. And lastly, he went and crafted ACTG sites across the country and an HPTN site here at GW to form the Terry Byrne CPCRA Community Trials Unit. So these are important organizations, but most importantly, I think he wanted the community to have a voice. And so he brought the community, those persons most affected by their diseases of HIV and tuberculosis, to the design and implementation of clinical trials. So as we remember Fred today and always, we are often reminded of his legacies to bring joy to the practice of infectious diseases in medicine, which he taught us as a teacher. As a physician, to be always mindful of patient care and that it should be informed by science in a well-done manner. Fred's ultimate goal was to actually do science well, to inform clinical care for the best provision of care and inclusion for his patients within Washington, D.C. and beyond. And this goal is one that we should all aspire. Thank you.
Thank you, Jenny, for those moving and eloquent words. Dick. I have the great honor of introducing to you this morning our keynote speaker, Dr. Richard Chassan, who is widely recognized as our nation's foremost scholar in HIV and TB research. Dr. Chassan is professor of medicine, epidemiology, and international health, and directs the Center for AIDS Research and the Center for Tuberculosis Research at the Johns Hopkins University School of Medicine and the Bloomberg School of Public Health in Baltimore. He received his bachelor's and his medical degrees from UMass at Amherst and trained in internal medicine, infectious diseases, and clinical epidemiology at UCSF. He has been a PI of the CDC's TB Trials Consortium since its inception in 1994, leading clinical research sites in Baltimore, Rio de Janeiro, Brazil, and Soweto, South Africa. From 2002 to 2014, he organized and led the consortium to respond effectively to the AIDS-TB epidemic, called CREATE, a research consortium studying novel public health approaches to reduce the burden of HIV-related TB. Dr. Chassan has published over 500 scientific papers and chapters. In 2012, he reestablished the Johns Hopkins Center for AIDS Research, revitalizing a multidisciplinary program to catalyze innovative HIV research with a special focus on combating the Baltimore epidemic. Since that time, Dick has been a great friend of the DC CFAR, inviting me personally to serve on Johns Hopkins Advisory Board, fully supporting the Mid-Atlantic CFAR Consortium that we've established along with the Johns Hopkins CFAR and the University of Pennsylvania CFAR, and most recently reaching out to DC to join forces in the new End the HIV Epidemic initiative. Moreover, as you will soon learn, Dick has personal connections to both Fred himself and our awardee today, Dr. Sebleh Kasai. Dick, thank you for agreeing to give this most important keynote lecture.
Well, good morning. First, let me thank Ann Willoughby, Jonathan, and Dana Gordin for being here and for agreeing to let me honor Fred at this really important inaugural lecture. I'd like to thank Alan and Gary and the DC CFAR for their camaraderie, collaboration, and support, and for asking me to come today. Let's see. And it's really a touching honor to be asked to give any memorial lecture, but a memorial lecture for Fred is really just an extraordinary gift to me, and I can't thank you enough for asking me, and hope the next few moments will be worthy of your trust in me speaking today. I'll just briefly disclose all of my financial entanglements. So, I lived a parallel life to Fred Gordin. We were on the parallel track for 37 years. And though Plutarch didn't write about us, I think as I reviewed this history, I found it rather remarkable. Our parallel lives were not on separate tracks, however, because they frequently intersected. And so I want to tell you about those 37 years of being on the parallel track with Fred, and then talk about one of the main goals of the work that we did, both individually with different colleagues and jointly together. So in 1981, Fred was the chief medical resident at Georgetown Medical Center. It's not working. And I was a visiting fourth-year medical student at Georgetown Medical Center on the pulmonary service. Something that I had forgotten. I didn't forget Georgetown. I forgot that I had been there at the same time as Fred until I was reminded recently. But I continued to stalk him. Fred left for a fellowship at UCSF in infectious diseases at San Francisco General Hospital, and I left to become a resident and infectious disease fellow at UCSF and San Francisco General Hospital. San Francisco General Hospital was an extraordinary special place at the time, and it still is. But at San Francisco General Hospital, there is the famous Ward 86, the original AIDS clinic, the first AIDS clinic in the world, where Fred and I both worked. And there's also Ward 94, less renowned, but equally important in the history of infectious diseases, the TB clinic. And they're in adjacent buildings that are connected, and Fred and I shuttled back and forth between them. Fred worked with John Mills, the chief of infectious diseases, and did some important work on prevention of pneumocystis and treatment of pneumocystis, and this paper on the side effects of trimethoprim sulfa in patients with AIDS. I also worked with John Mills. You probably can't see this too well. My output was probably less cited. Nonetheless, John and I worked together. And here's Fred with John in Melbourne a few years ago. John was a great friend and teacher to both of us. And there's Fred with Ann and Dana and Suzanne Crowe, John Mills' wife, who he left San Francisco and followed to Melbourne and has been there happily ever since. Fred worked with Phil Hopewell, the chief of the pulmonary service at San Francisco General. This paper on tuberculin skin testing was cited by George Comstock as one of the most important papers on tuberculin in history. George Comstock, for those who don't know, is the leading epidemiologist in the history of tuberculosis, and he used this in his course. I also worked with Phil Hopewell. And Phil was my advisor on a research project. And I designed my first research project as a fellow, and I took it to him, and I said, what do you think of this? And he said, you could do that, or you could do something important. So I abandoned that project and did something important, looking at the overlap of TB and AIDS in San Francisco, a paper that I'm proud to say has been cited 700 times since it was published. Fred returned east to Washington and the VA Medical Center, and I returned east to Johns Hopkins and ran its AIDS service for 10 years before starting the TB Center and branching out into even more things. In the early 90s, Fred and I both focused on Mycobacterium avium infection, or MAC, because this was a leading killer in people with HIV, and there was no effective treatment or prevention. And we worked together with colleagues around the country to do a study, a landmark study on the prevention of MAC in patients with AIDS, published in the New England Journal of Medicine. And we then went on to go on the circuit to advise doctors around the country about rifabutin for the prevention of MAC. Fred is ageless, of course, and that's my son. You'll be interested to know that any Microsoft product, Word, PowerPoint, if you type in the word rifabutin, it will autocorrect to highfalutin, which kind of describes our activity. Fred, as you heard, organized and led the CPCRA with his colleagues and really dove into his first major study of TB and HIV, this trial published in the New England Journal of Medicine on prophylactic therapy with isoniazid. Through the ACTG, Fred and I collaborated on an important study looking at short-course preventive therapy for tuberculosis in patients with HIV, which is really the subject of this talk, and I'll return to this later. But Fred led the CPCRA, I led the ACTG involvement, and together we carried out this large international randomized trial. We both worked in the TB Trials Consortium and published a paper in The Lancet on rifapentine and isoniazid once a week, an intervention that sadly was not adequate for treatment of tuberculosis, but rifapentine has gone on to live another and better life that you'll be hearing about and has great promise for the treatment of TB. And also shout out to Deborah Benader, who, as you can see, is the first author of this paper, and a great team for us to work with. Fred, as you heard, was one of the co-PIs of the Insight Network. He and I continued to work in the TBTC and the ACTG together. I was on the Insight Data Safety Monitoring Board, so I got to see the results of all of Fred's studies before him. And I couldn't tell him about it, but as you heard, the START study that was done by Insight is one of the most important studies in the history of HIV. I think this paper has been cited over 6,000 times since it was published, and Fred was one of the co-chairs. And then in more recent years, Fred and I have worked together on the Advocacy and External Relations Committee of the TB Trials Consortium, trying to generate support for TB research. This is what happens when you become an old dog. They ask you to go out and beg for money. And so Fred and I did a lot of begging together. So I led a parallel life with Fred, and I want to go back to the beginning of it. Actually, Georgetown, there really wasn't a lot of interaction, but at San Francisco General Hospital, it was really the foundry for what came after for both of us. It was an extraordinary time in history, and it was an extraordinary place to be. With these two clinics and the patient population that we served, we came to realize that there was a new disease that was really unprecedented, that was meeting an old disease that was probably underappreciated. HIV was completely new to mankind, out of the blue. It was called GRID. It was called many things. It was called AIDS eventually, then ARC, and then eventually HIV. The response to this was driven by discovery. We had to find out what was going on, and we had to find out what to do. Nobody knew. One of the nice things, if there was a nice thing about working in HIV back then, was you never had to go to the library because there was nothing to read. You got to write it. We wrote the history, we wrote the science. It was also a response driven by the community, and as you heard from Ginny, Fred was extraordinarily engaged with the community. Tuberculosis was kind of old and boring, been around forever. There was an abundant literature that you never wanted to read, and it was considered a solved problem. A very prominent infectious disease doctor in San Francisco, who I won't name, but who both Fred and I held dear, said to me in 1987, "Why do you want to waste your career studying tuberculosis?" But that was the sentiment at the time, that this was a solved problem. There's nothing new to discover. There have already been 3 Nobel Prizes for TB. What's left to do? It turns out there was a lot. And what we have found that, what we subsequently found is that, in fact, the twain did meet, and from that synergistic and catastrophic collision of epidemics, we really learned a lot about both. And that's really where I want to go for the remainder of my time here. So, where are we today with tuberculosis? So, tuberculosis is as bad as it ever has been. There are 10 million cases in the world in 2017, and 1.5 million deaths. HIV-related TB is about 10% of all TB, but 20% of all deaths. And multi-drug resistant TB is a huge problem. So these two epidemics are entwined, but tuberculosis is really a monumental problem. Tuberculosis has eclipsed AIDS as the leading cause of death in the world. And you can see that if you look at the blue bars here, those are deaths in people without HIV. And even there, it eclipses all of HIV and AIDS. I'm sorry, in the gray, it eclipses it. And HIV and AIDS is the second leading cause of death in the world. So these are two still monumental challenges to global public health. Just to get a sense of how deadly tuberculosis is, I'll describe a little study that my colleagues Tanvir Omar and Neil Martinson, a husband and wife pathologist epidemiologist team in South Africa, led, where they went to funeral homes in the northwest province of South Africa and asked to speak to the families of people who had died of natural causes at home without a diagnosis, without having seen a doctor, and without ever having been in the hospital. And they were given on their death certificate a diagnosis of natural causes. Turns out that 18% of them actually had TB that was known, so they weren't included. And from the remainder, they got consent from the family to do a lung biopsy and a bronchoalveolar lavage, and found that 1/3 of them had tuberculosis. So 1/3 of deaths at home attributed to natural causes were actually from tuberculosis. And tuberculosis is already the leading cause of death in South Africa, and these were additional cases, additional burden that wasn't appreciated. So with that backdrop, we now have an extraordinarily ambitious global plan to end TB by 2035. The WHO, the UN, have declared that by 2035 we'll end TB with a 95% reduction in the number of TB cases, a 90% reduction in incidence, and a complete elimination of catastrophic financial costs due to people suffering from TB. And these are really overly ambitious, perhaps. You can't have too high a goal, I suppose, but these are extraordinary targets that we're supposed to reach at the time when tuberculosis is as bad as it's ever been. So let's just talk a moment about the community and population dynamics of TB and what we can do to address this challenge. So tuberculosis begins with infection. You have to have infection to get disease. The reservoir infection is essentially all human, and it's about 2 billion people in the world have latent TB. Some number of those will develop active TB in any given year, and those who have active TB can spread it to those who are uninfected and susceptible. And of those who are infected, about 2 to 3 million a year will develop disease immediately or shortly after becoming infected, and the rest of them will go back into this latent pool and be at risk in the future for developing TB. Since 1974, the global strategy for controlling tuberculosis has been find the cases and treat them. If we find the cases and treat them, they'll stop transmitting. Treatment as prevention. And treatment as prevention works, but it isn't adequate to end the epidemic, because that pool of latently infected people will continue to progress to disease until that pool is exhausted. So treatment as prevention is okay, it's good, it's important, but it's not enough. What about preventive therapy? Well, for preventive therapy can prevent people who have latent infection from progressing to active disease. And as George Comstock liked to say, if you think very simplistically, if you turn off that tap, there's no more epidemic. Now, turning off that tap is a huge challenge. Nonetheless, this is where preventive therapy has an important role in ending the epidemic. And a vaccine is something that was considered science fiction just, I would say, even a year ago, but now may not be science fiction, may be science for people who are already infected. Reducing the things that drive TB, like treating HIV infection and other comorbidities like diabetes, is also something important. And if we had a new TB vaccine that actually worked for people who aren't infected, then we could also have a large impact. But none of these is sufficient. We need to really address all of them. There's been a lot of modeling, but perhaps the most informative and simple model is this one developed by Chris Dye from the World Health Organization on where we currently are. And you can see where we are at the top. The baseline is things are pretty flat. TB isn't going away, that we're not heading towards a 90% reduction. And if we mitigate risk factors for TB, like diabetes, even like HIV, we can have a small impact. If we prevent infection through case finding, better case finding, we can have a small impact. If we treat active TB better, find the missing cases and treat them, we can have a bigger impact. And if we treat latent tuberculosis much more aggressively, we can have a huge impact. And if we do both treatment of active and latent TB, we can reach the elimination targets. This is a simple model, but it really underscores the dynamics that I showed you of how TB behaves in populations. So how do we prevent TB? Well, we try to prevent infection. We prevent it through controlling transmission in healthcare environments, but by finding the cases and treating them. Treatment is prevention. And if we had a vaccine that worked, that would be where it would work. We can reduce susceptibility, most importantly, by treating HIV, but also tobacco control. Tobacco is a great risk factor for developing TB, preventing and treating diabetes. But fundamentally, chemoprophylaxis is our most effective tool. The START study showed that antiretroviral therapy had a huge impact on TB. The START study didn't offer TB preventive therapy as part of the protocol. It was allowed, but it wasn't offered, and hardly anybody got it. But with just early antiretroviral therapy, you can see the immediate group on the left had a TB incidence rate of 0.09% per year compared to 0.28%, a very significant 71% reduction in TB just with antiretroviral therapy. And we and others have shown in other observational cohort studies that ART is great, and it does reduce TB, but it doesn't do enough. Anti-TB preventive therapy is great, but you really need to have them both in order to get maximal benefit. So how do we prevent TB? The prevention of TB goes way back. So George Comstock led a study in the western part of Alaska in the 1950s called the Bethel Study, where he did a community-wide intervention to prevent TB in Alaskan Eskimos who at the time had a TB prevalence of 2%, 2,000 per 100,000. Just extraordinary, double what it is in Swaziland right now. 70% of children became infected with TB by the time they went to school at the age of 8. It was a very poor environment. People lived in crowded housing, 6 people per house on average, and 2/3 of the houses had one room. And as Dr. Comstock Riley wrote in his paper, it was a climate that discourages ventilation. And he randomized the entire community by household to receive either 1 year of isoniazid or a placebo. It was the first cluster randomized trial in history, and it was done that way because it had to be done that way, but that was the invention of the cluster randomized trial. And what he showed is that after a year of isoniazid, there was a 70% reduction in tuberculosis in those households that received it, and over the subsequent 5 years, there was an overall 60% reduction in TB. And this was half of the population, because he treated everybody. So 60% reduction in half the population means that this preventive therapy reduced TB by at least 30% for the entire population. But in fact, you can see there was a secondary benefit because those people who didn't get TB didn't transmit it. So TB really declined dramatically over this time in this population. And this was the demonstration that this worked. Dr. Comstock, before the invention of IRBs, the field of bioethics, community advisory boards, decided that the people who benefited, who gave us this important finding, needed to benefit from it. So he went back and gave everybody isoniazid. And the people who'd had 1 year were offered a second year, and the people who'd had none were offered a first year. Not everybody took it, and because of that, he was able to go back and do an analysis 25 years later, looking at the optimal duration of isoniazid preventive therapy. And what he found was that 6 months was good, 9 months was better, and after 9 months, there was no additional benefit. So he said 9 months looks like the right duration, and that became the U.S. guideline in the CDC, ATS, IDSA guidelines in 2000. So this underscores one of the problems, that TB preventive therapy takes a long time. It takes too long. 9 months is too long for most people. 6 months is too long for most people, as we'll see. Is there other evidence that TB preventive therapy works at the community level? We did a study in Rio de Janeiro a few years back where we compared two strategies for TB control. One was using the DOTS, WHO approach of supervised therapy and so forth. And then what we called DOTS ampliado, or enhanced DOTS, where we also did contact screening and preventive therapy for those contacts who were infected. This was a policy in Rio and all of Brazil and essentially all of the world that had never been implemented. Nobody does it. It's just a policy in virtually every country of the world that's ignored. So we identified all the household contacts. We found that 4% of them actually had TB. 60% had latent TB, and we were able to effectively treat 60% of those contacts. And over 5 years in the communities where this was done, there was a 15% lower risk of lower incidence of TB than with the DOT strategy alone. Now, this also shows that this is definitely an improvement, but it's not the answer because the rates of TB are still high, so more needs to be done, but this confirms that there's a community-level benefit. We then looked at the HIV population in Rio, and this was part of CREATE, the TRIO study, where we trained clinics that treated HIV patients to do what they were supposed to do according to policy, which is screen HIV patients for TB and give them preventive therapy if they have latent TB. On the books, not done. So we were able to train the clinics in a step wedge fashion so that we could look at a randomized intervention before and after the clinics were trained. And we showed that over time, there was a 27% reduction in the incidence of TB and a 31% reduction in the risk of TB or death from this intervention. So at a population level, tuberculosis preventive therapy works. Now, also important here, of course, is antiretroviral therapy, but TB preventive therapy has additive benefits. In West Africa, in the Temprano study, it was shown that giving early ART or giving early or any isoniazid preventive therapy, IPT, reduced the risk of death, of progression to a serious AIDS event, and specifically of TB. And it was clear that getting both was better than getting either alone. And clearly better than getting neither. So this is a study that's just like the START study. These were people who didn't have indications at the time for antiretroviral therapy and were randomized to get it or not, with or without INH preventive therapy. And in a follow-up study, they showed that just getting the TB preventive therapy reduced the risk of death by 37%. And this was independent of ART, but getting them both was best. So we have abundant evidence that there's a benefit of TB preventive therapy. And as I said, it's just not done globally. These are WHO data on the uptake of TB preventive therapy in people with HIV. The target here is 30 plus million, and you can see we're down near 1 million. It's just an extraordinarily poor performance globally of TB preventive therapy. It's just not being done. For children, household contacts, it's not being done. This is a study that one of my colleagues, Nicole Salazar-Austin, a pediatrician at Hopkins, did in South Africa in the Northwest province. And she looked at household contacts of newly diagnosed TB patients. We knew from an intensive community-based study that we had previously done how many cases there should have been. But we found of the estimated 800 children under 5 who were exposed to TB, only half of those were named by the patients. And there are lots of reasons why patients don't name children in their household, because they don't want to come back and sit in line for 5, 6 hours and waste a day and not get paid for work to have a healthy child evaluated. But they need to be evaluated. Of those identified, only half made it to the clinic. Most of them got started on preventive therapy if they made it to the clinic, but few of them completed it. So the cascade of care for TB prevention in children is really damaged. So how do we do a better job of getting TB preventive therapy to the people who need it? There are lots of steps, making the testing for infection easier and better, screening people more effectively, but making preventive therapy easier, safer, and shorter is really the key. It's the long duration of therapy that has clearly been documented to interfere with uptake and completion. And then once we have these regimens, we need to convince the programs and the clinicians and the patients to accept it and use it, because that's a huge obstacle. So how do we find better regimens? There are really two pioneers in this area, and certainly Jacques Grosset is a legendary figure in tuberculosis and preventive therapy in particular. Dr. Grosset spent most of his career in Paris, in Algeria at the Pasteur Institute, but at the age of 70, they kicked him out. We invited him to Hopkins as a visiting professor, and he stayed for 17 years. Got about 5 NIH grants, a couple of grants from the Gates Foundation, multiple other grants, and had the most productive period of his life, beginning at age 70. Any of you thinking of retiring, come on up to Baltimore, and we'll stick you in the lab. And his protege and successor, Eric Nürnberger, working with BALB/c mice, have really done an extraordinary service to tuberculosis treatment and prevention by developing a model that really tells us what will work in people. So the model, just briefly described here, is that they immunize mice with a recombinant BCG, and then they later infect them with virulent TB at a low dose by an aerosol route, and then they treat them. And you can see on the right that if they're untreated, the infection goes out of control, but if they or rather if they're not immunized, but if they're immunized, they develop a stable, low-grade infection. And they're healthy, but they have TB infection, and this mimics in a model latent TB infection in humans, and we can test different interventions. So one of the first interventions in this model, published in 1989 by Grosset and his colleagues, was looking at a couple of drugs, but in particular rifampin and pyrazinamide in the triangles was highly effective at sterilizing the mice in 2 months. So on the basis of about 120 mice in a basement in Paris, we went out and did huge clinical trials all over the world because there's no phase 1 or 2 that you can do for TB prevention. There's no surrogate marker. The first one was a study that Neil Halsey and I led in Haiti, funded by the CDC, where we took people with HIV infection and randomized them to rifampin and pyrazinamide twice weekly, for 2 months, or INH twice weekly for 6 months. And this was before ART was available in Haiti. Haiti suffering a terrible HIV epidemic, a terrible TB epidemic, and a terrible political situation with extraordinary poverty. In this setting, we were able to show that rifampin and PZA were equally effective to isoniazid at preventing TB in these HIV-positive patients, and it was safe. In the CRA-ACTG trial that Fred and I led, we also showed that rifampin and PZA given daily was as effective as isoniazid given for a year. 2 months was equal to a year. And it was also safe. It was actually safer than isoniazid. If you look at liver toxicity, the most important toxicity, significantly less with rifampin PZA. It does cause narcotic withdrawal, and a number of patients in this study were in methadone programs, and that certainly was an adverse event that was unwelcome and can be overcome. So this made it into U.S. guidelines, made it into WHO guidelines. This was a great advance. And then as soon as it went out into the rest of the world, disaster struck. And it turned out that rifampin and PZA in HIV-negative people wasn't safe. Now, this remains to this day a complete enigma. There's no good explanation for it. Nonetheless, it's a very real event that people without HIV who can be treated for active TB with rifampin, PZA, and other drugs, if you give them rifampin and PZA together, have a very high risk of developing hepatitis, and some of that was fatal. So this was pulled from the books, and that was a huge disappointing setback. So back in the lab, Grosset and colleagues were looking at something else. What about rifapentine, a drug like rifampin that's much more potent than rifampin and has a longer half-life? And he did several different experiments, but what I've circled here is showing for 13 weeks, rifapentine and isoniazid given once a week to the mice sterilized them. And so on the basis of 120 mice in a basement in Paris, we went out and studied 10,000 people all over the world. The first study was in Rio de Janeiro, funded by the NIH, and we used rifampin PZA as our control, and this was for HIV-negative household contacts of TB patients. And we enrolled about 400, and we're having low rates of TB. The study was supposed to enroll 800, but to our surprise, at the same time as this was being seen here in the U.S., 10% of the people given rifampin and PZA developed serious hepatotoxicity versus 1% with rifapentine. So we're unable to complete the study. We declared victory and withdrew, saying we've proven that rifampin PZA is too toxic and rifapentine INH is safer. We then went on to do a study in South Africa looking at rifampin PZA given once a week for 12 weeks, or 3HP as it is called, and a couple of other regimens. And this is just an explanation that we used to recruit patients of what the treatments were. So the 3HP in the upper left, you can see once a week. They took it in the clinic for 12 weeks and they're done. We also looked at rifampin INH twice a week, same thing. INH at home for 6 months, the control, or what we called continuous INH, which was INH forever. Just go on it and never stop taking it. These were HIV-positive adults in Soweto, South Africa. And what we found is that the regimens were all similarly effective. The lifelong INH was no better than the short course regimens. unless you took it. But it turns out that most of the people stopped taking it, and as soon as they stopped taking it, they lost the benefit. So in a practical, real-world setting, lifelong INH wasn't any better. This was followed then by study 26 of the TBTC that Fred and I were very involved in with Tim Sterling and many colleagues, looking at 3-HP versus 9 months of isoniazid in largely HIV negative, but not entirely HIV negative, largely household contacts of TB patients. And what you see on the left is that the risk of TB was actually lower with 3-HP than it was with isoniazid, but the p-value was 0.06. So we were not allowed to declare that it was better, though it clearly is. And I was delighted to see a friend of mine at Yale Nursing School sent me an article in Nature this morning about attacking the p-value and orthodoxy over the p-value. That's something that George Comstock taught us too. He never published a p-value. He said, your data speak to you. You can see what the results are. You don't need a p-value to tell you that this is important or not important. P-values are useful. So I'm in a school of public health. There's probably a floor full of statisticians over my head. But let's not be slaves to them. And a p-value of 0.06 means that instead of a 5% chance you might be wrong, there's a 6% chance. Close enough for government work. On the right, you see the performance of the regimen in HIV positive individuals. Again, the 3-HP was superior, not statistically superior. So we have a regimen now that can be given in 12 doses in 3 months that's actually safer and as or more effective than the standard of care. And one of the things that this study pointed out is that even though there was a higher slope of the rate of discontinuations with the 3-HP, overall, many more people were able to complete their 3-HP because it was over sooner. And the longer you have to take it, the more opportunities there are to give up. And that's what happens with TB preventive therapy. People give up and they just stop, and it doesn't work when you give up. Now, I have to say that one of the most gratifying outcomes of these studies that I've just shown you was not our papers in the New England Journal of Medicine, but this commentary in the New England Journal of Medicine a couple of years later from people at the University of Washington and King County Health Department in Seattle, showing that they were able to use 3-HP to end a TB epidemic in the homeless in Seattle. And they said this tool of a once-weekly regimen was really important in interrupting the transmission and progression of TB in the homeless population. They teamed with a bakery in downtown Seattle. The bakery agreed to allow the homeless to come in on Saturday mornings, get food, coffee, drinks, and 3-HP, and it was a great partnership. We are currently working to scale this up in 13 countries around the world, funded by the UN agency UNITAID, working with Gavin Churchyard at the Orem Institute and colleagues at KNCV, the Clinton Health Access Facility Initiative, and TAG, the Treatment Action Group in New York, through getting rifapentine available at a low price, training clinicians, getting it onto national formularies, and making it available for the people who need it, primarily people with HIV and children who are contacts of cases. Now, another short course regimen recently evaluated is rifampin by itself for 4 months versus 9 months of INH. Dick Menzies led 2 large international studies in adults and children showing that 4 months of rifampin was safer and as effective, non-inferior to 9 months of INH. So when we finished up the 3-HP studies, Eric Nurnberger went back to the lab and said, can we do better? We were pretty pleased. Wow, we got it down to 12 doses. And he said, yeah, let's see if we can do better. So we looked at giving a rifapentine, abbreviated here P, and INH-H to mice daily at high doses, the high dose of rifapentine, for just a month. And it turns out it was just as effective in the mice as the 3-month regimen. So we said, why not study it? So we did the brief TB study in the ACTG. Sue Swindles from Nebraska, the co-chair with me, and this was a study of 1 month of daily rifapentine isoniazid in people with HIV infection. Open label, 3,000 people, 97% in high burden countries, and the control regimen was isoniazid for 9 months. And we had a good long follow-up period. We accrued fairly rapidly, and you can see large numbers of people from South Africa, from Peru, Botswana, Haiti, Thailand, so an internationally representative population of people with HIV. And what we found was that the rates of TB or death from an unknown cause, which we have to attribute at least in large part to TB, were the same. The incidence rates were 0.65 versus 0.67, so the 1 HP a little better, but not significantly better, but clearly non-inferior, which was our goal. This was a non-inferiority study. It was safer. You can see the time to developing TB here, no difference. Even when you stratify by CD4 count, no significant differences. And if we look at, in the study, the predictors of developing TB, the higher the CD4 count, the lower the risk, of course, we know that. The higher the BMI, the lower the risk, we also know that. And people who had a positive IGRA, interferon gamma release assay, or tuberculin skin test, were more likely to develop TB than those who did not. The people who got the 1 HP were more likely to complete, although the completion rate for the 9-month regimen was extraordinary, and it's the highest published completion rate in history. And that just speaks to the extraordinary quality of the ACTG teams all over the world who don't let people quit. So this is really a pure effectiveness trial, not an efficacy trial, not a clinical effectiveness. And discontinuing because of toxicity was less common with the 1 HP. So we have a great now 1-month regimen for people with HIV. We need to study it in people without HIV because that rifampin PZA experience seared my brain, and it's really important. But the question is, are we there yet? Have we reached nirvana? Have we gotten the perfect regimen to go out there and end TB? We've gone from 12 months to 9 months to 6 months to 4 months, 3 months, and now we're at 1 month. Well, as we finished up this study, Eric Nornberger went back to the lab, said, well, we can do better. So there's the 1 HP regimen in the mice. This, by the way, is bedaquiline, abbreviated as J, but it's bedaquiline, the new drug that's active for MDR-TB. 1 month of bedaquiline is as good as 1 month of rifapentine and INH, except it would work for people with MDR-TB or XDR-TB infections. So that's rather extraordinary. Unfortunately, it's not being studied right now, though there's an effort to get it studied. If you combine bedaquiline with rifapentine, it's much better than either. So maybe we could get it down to 2 weeks. And if you combine it with PZA, it's completely sterilizing. And so maybe we can get down to 1 to 2 weeks of treatment. And that would just be truly revolutionary. Now, in the HIV field, there's also a lot of interest now in long-acting injectables, LAIs. In TB, we've been trying to get rid of injectables. Everyone hates them because they hurt and they cause deafness and kidney failure. So we hate injectables. In HIV, people love injectables. Just give me a shot and I'm good for 3 months. So Eric and his colleagues are now looking with collaborators at Janssen who make bedaquiline at a long-acting injectable formulation of bedaquiline. And what you see in this study just published a few weeks ago is that even with a single dose of this injectable bedaquiline, if you go out to 12 weeks, it's essentially the same as if you give 3 consecutive doses. So this is a potentially promising approach. But a lot of people also say in the hallway outside the meeting, if you can take it for a month, or even 2 weeks. Why would you want an injection? And I think that remains to be seen. But certainly there are lots of exciting opportunities. Now, I said something about vaccine earlier. A vaccination for an established infection was never thought to be feasible. How would that work? Your body has all this bug, all this antigen. How is, a couple of microliters of protein or whatever your protein and adjuvant are going to be better than the natural infection in providing protection? So it wasn't a model that made much sense. Nonetheless, the folks at Glaxo developed a vaccine, the M72 AS01 adjuvant vaccine, and decided to test it in people who were already infected with TB, largely adolescents, young adults. And they found in this preliminary study that it reduced the risk of developing TB over a couple of years by 50%. So this is kind of wild, and this, really opens up a lot of possibilities. But the first thing that has to happen is this needs to be replicated and validated. And then if it is validated, then we really need to think about what the role of vaccine is versus the role of preventive therapy. Because if you think about it, and as I showed you in that population model, they do the same thing in terms of an intervention, prevent people with latent TB from becoming people with active TB. But I think this is no longer a pipe dream, but it's still pretty much a dream, and a lot more work needs to be done. I want to end by talking about why this hasn't been done, why preventive therapy hasn't been done. And I call it TB preventive therapy denialism. We heard a few years back about AIDS denialism in Africa particularly. It's a little bit like climate change denialism. It's stubborn, it's uninformed, but it doesn't seem to go away. But that AIDS denialism, has largely gone away, but the TB preventive therapy denialism has not. National TB programs, national HIV programs, even organizations like PEPFAR have been reluctant to do this until this year. PEPFAR has finally embraced TB preventive therapy, I would say with gusto, and I think that's great. But if you think about what happened in the 10 years after the WHO recommended that all people with HIV should get preventive therapy, and nobody did, there were 10 million deaths. The Temprano study tells us that we can reduce mortality by 37%. So does that mean we had over 3 million preventable deaths from tuberculosis in people with HIV from failure to implement a policy? There was outrage in South Africa when they said there were 300,000 deaths from failure to implement antiretroviral therapy under Thabo Mbeki. Well, this is us who didn't do this, and it's really a scandal. But as I said, things are changing. Jonathan Golub and I, when the Temprano study came out, wrote this editorial in Lancet Global Health saying, there are no more excuses. There's no reason that you shouldn't be doing this. We've really failed people with HIV by not implementing preventive therapy. So the climate has changed a lot. In September of last year, not 2019, I just noticed, the UN held a high-level meeting at the General Assembly on ending the TB epidemic, and committed to ending the epidemic by 2030, a little more ambitious than the WHO. And this includes treating 40 million people with TB in the next 5 years, and providing TB preventive therapy to 30 million people in the next 5 years, including people with HIV, household contacts, and others. Importantly, it's calling for increased investment in TB and getting up to $13 billion per year going into TB, which is a fraction of what goes into HIV, by the way. So this was a really important development. This is Cyril Ramaphosa, the president of South Africa, one of 15 heads of state who spoke rather eloquently about TB and ending the epidemic. Ramaphosa, quoting Nelson Mandela. Nelson Mandela spoke at the Bangkok AIDS conference at the launch of our CREATE project, saying we cannot conquer AIDS if we don't pay attention to TB, and he was quoted there. And then just today, actually, officially, the Lancet TB Commission published its report in Lancet, an initiative led by Eric Gooseby, the special UN ambassador, former head of the Office of the Global AIDS Ambassador, and now a professor at UCSF, who Fred and I worked with as fellows out there. And this calls for ending the epidemic through investment in treatment programs, investment in prevention, investments in research, and really ramping up the global response to TB. So, we heard that Fred liked to have fun, and that he was famous for his costumes and his Halloween get-ups. So I think of Fred as a worker bee, though, not as a goofball. Fred's a worker bee to me. He was always the first one to sign up to take on a task. He was always the first one to be on the committee, to go to the meeting, to write the protocol, to write the report. And I think of that when I see this poem by Marge Piercy, and I invite you to look it up. It's a wonderful poem. But I just emphasize, I want to be with people who submerge in the task, who go into the fields to harvest and work in a row and pass the bags along, who are not parlor generals and field deserters, but move in a common rhythm when the food must come in or the fire be put out. That's Fred to me. He was in there, moving the bags, feeding the family. He wasn't a parlor general. He was a real worker bee. So we have HIV and TB as the two leading infectious causes of death in the world. We've come a long way since Ward 86 and Ward 94. We have effective tools, but they're not being used. And I think we still all have to, roll up our sleeves, get to work, and get the job done. That's what Fred would do, and that's what he would want us to do. Thank you. Sure.
We can take some questions if anybody would like. Anyone would like to put it? Do we need a presidential TB initiative like we have PMI?
So Alan is asking if we need a presidential TB initiative like PEPFAR, like the Presidential Malaria Initiative. I guess what I would say is it couldn't possibly hurt, but is it necessary? I don't know that it's necessary. There's so much that can be done without it. A presidential initiative would be great. I don't see that happening, but you never know. Who expected a end the HIV epidemic initiative this year? I didn't.
Is there enough money?
Is there enough money? Well, the costing modeling for this says there needs to be a huge ramp up in the amount of investment. There's enough money in the world, it's just not in the right places. So could this, is this something that could be done? It's, one thing that's different about TB than HIV is that the vast majority of funding for TB care comes from countries. It's not based on USAID, it's not based on the European Union, the Danish, we're all small players. It's the countries, because it's a problem for them and they've had it forever. So the international contribution, if it were made to be on the scale of HIV, would be extraordinary. So I think there is, but of course, how do you loosen it up?
Thank you. I'm Deborah. Is an on-off switch on the mic?
There we go. Is that it? Yeah, thank you. First of all, Dick, thank you for so beautifully honoring Fred's memory. That's incredibly elegant and incredibly a big picture, and I think we're very touched by the presentation, and I know the family is, and actually all of us who've worked with Fred over the years. So my question, what about, so it seems the injectables are something that surprised me. I think those of us who've been in HIV care for years and years wondered if folks would come to injectables. And what's surprising is how many people say what Magic Johnson says, which is, I only think of my HIV when I have to take that pill, and how important an injectable becomes in that setting. For TB, I'm wondering about injectable bedaquiline plus the vaccine. And I wonder if there's any science, and if perhaps that might be an approach that allows the patient is there with you, an injectable as they're there and you're done, but you increase the effectiveness. And so I wonder if there's any considerations, if there's any science in that consideration. Thank you.
Well, there certainly could be, and this is all brand new. I think this therapeutic vaccine is a shock to the world because we don't really have therapeutic vaccines for infections. They've never worked, and there's no reason why they should, except that this one apparently did. So with that new information, that's relatively new, very new, it just opens up lots of doors, and I think you've raised a good one. So what if you could have somebody come in and get a shot and think of it like benzathine penicillin? You're done, off you go. We don't have to worry about, you don't have to go to the pharmacy, you don't have to be adherent. I think that has potential. So I just think there's lots of important research to be done. Like I said, we finished 1 HP and thought, wow, this is great. And Eric said, no, we can do better. So, and maybe we can do better than just a vaccine. So we'll look forward to getting your concept sheets submitted for future studies.
Thank you, Dick, for an absolutely magnificent talk. Truly honored Fred's memory. Ooh. All right, I think we're going to move to the next portion. Patty, could you help me here? We're going to invite up Anne Willoughby, Fred's wife. Anne, we have a small tribute for you. This is honoring Fred as the founding director of the DCC4 Clinical Corps for your mantle.
Thank you very much, Helen. I want to thank Drs. Greenberg and Simon and Kahn, all long-term colleagues and friends of Fred, for organizing the Fred Gordin Memorial Lecture. This week is especially meaningful for all of us because Monday was the first anniversary of Fred's death, and coincidentally and ironically, the first anniversary of the death of his colleague David Cooper in Australia. I want to welcome all of the colleagues, family, and friends who came today to remember Fred, and I want to thank Dr. Chasen for a very wonderful lecture. Fred would have loved it. Fred was my husband, the father of our children, Jonathan and Dana, and my best friend. We met at medical school in 1975 and were married in 1981. If there were three things that I would want everyone to know about Fred, the first is that he was the ultimate family man. Not only to his immediate family, but to his large extended family and to my family. He kept close contact with family from DC to Texas to California to New York, South Carolina. We often traveled with the purpose of visiting and staying with family. There was no family concern that he did not respond to, and there was no family member that he didn't love. The second thing was that Fred had a special gift of friendship. Most of his close friends were like family. He was friends to people he knew in middle school and high school. We often traveled to California to visit friends he knew as a child and others that he knew from medical school. One of Fred's close friends said to me shortly after his death, "You know, the thing about Fred was he was everybody's best friend." I couldn't have said it better myself, and many of his colleagues became his best friends. Shortly before his death, he said, "Tell everyone that I love them. You know who I mean." He meant his family, friends, colleagues, and all of you in this room today. The last thing that Fred had was an adventurous sense that expressed itself in traveling on family vacations all over the United States, Europe, Australia, and Africa. He always planned each trip down to the tiniest detail, and always, for better or worse, he drove himself. He introduced me and our children to other countries, and yes, whenever he met someone on travel, he had an immediate sense of brotherhood and connectedness. In the short time left, I'd like to read to you a beautiful poem written shortly after Fred's death by his friend and colleague, Dr. Rhea Kierbeck. Rhea, are you here today? Okay. It captures much about his life and death and who he was. It's called In Memory of Fred. At the time of night prayers, when the sun slides down, when all is silent and the roads to the invisible open, I see Fred on Judgment Day standing with scores of patients behind him. They whisper, "Oh, Almighty God, God of Moses and Abraham, spare him, for he once saved my life." It's too sad to see Fred struggle, and it's too difficult to say goodbye. Patient yet longing, his soul left this realm of existence and went back to its first and last home. Watching the tent of the universe quiver, handing out cups full of pills, constantly afraid to touch and afraid to love, the teacher always knows what his students think, and how long does one remain frightened of tomorrow? Into the eye of the storm, through turbulent desert, racing death on a horse with a broken bridle, with no more certainty than a bird suddenly released, yet with an open mind. As Dick said, Fred sees enormous possibilities, and with his will, he turns them real. Lazarus of his time, a dust particle makes its way inside an oyster and becomes a pearl. Born from a spark of a stone, lightning in his presence and shattering myths. At the time of night prayers, when the sun goes down, when all is silent and the roads to the invisible open, I see Fred on Judgment Day. Standing with scores of patients behind him, they whisper, "Almighty God, God of Moses and Abraham, spare him, for he once saved my life." Thank you.
Okay. Anne has chosen a musical piece that she'd like us to listen to. Yeah. Maybe you could cue this up.
Yeah. Moses Supercharger is a Ugandan artist and musician an AIDS activist. He composed a song sung by a women and children's group and honors not only Fred's work, but Fred's colleague and friend David Cooper, who, as I said earlier, ironically died in Australia on the same day Fred died. I'll read the words of the song. They're a little hard to understand, and I hope you enjoy the beauty of this song. I listen to it almost every day. It begins with a refrain: Fred Gordin, David Cooper, super canoes of our boats. We miss you ever since you left us. We're stranded in the Nile. David Cooper, Fred Gordin, brothers gone too soon. Our pillars, energizers, we miss you every day. Struggling every minute to accept the truth you have gone, staring at the achievements we got together with you. You left this earth like rays of departing sun. Memories of your smile create big cracks in our hearts. Insight will always remember the wisdom you put in research. Significant roles you played improve the quality of our lives. Outstanding teachers, brave leaders, the candles of research. Let your souls rest in peace as we celebrate your lives. Stained windows sparkle in the sun when it's shining bright, but they end up losing beauty when the darkness folds the earth. The bitterest tears we shed were because of losing you. Community will always salute you for the good jobs done for us. We pray that your wives and children will always be together and strong. The pain you had before ended, now rest in peace. Your vision, goals, and roles will always be our daily jobs. We shall never, never let you down. Fred Gordin, David Cooper, we miss you so much. Rest in peace, brothers.
Dear Fred Gordin and David Cooper, we miss you so much. Rest in peace, brothers.
Fred Gordin, David Cooper, super connors overboard. We miss you ever since you left us. We're stranded in the Nile. David Cooper, Fred Gordin, brothers gone too soon. Our pillars, energizers, we miss you every day.
Struggling every minute to accept the truth that you are gone. Staring at the achievements we got together with you. You left this outlet rays of departing sun. Memories of your smile, great big cracks in our hearts.
Fred Gordin, David Cooper, super connors overboard. We miss you ever since you left us. We're stranded in the Nile. David Cooper, Fred Gordin, brothers gone too soon. Our pillars, energizers, we miss you every day.
Insight to love rays, remember the wisdom you put in research. Significant roles you played improve the quality of life. Outstanding teachers, bravery leaders, the candles of research. Let your souls rest in peace as we celebrate your life.
Fred Gordin, David Cooper, super connors overboard. We miss you ever since you left us. We're stranded in the Nile. David Cooper, Fred Gordin, brothers gone too soon. Our pillars, energizers, we miss you every day.
Stained windows sparkle as the sun is shining bright, but they end up losing beauty when the darkness folds the earth. The bitterest tears we shed were because of losing you. Community will always salute you for the good job done for us.
Fred Gordin, David Cooper, super connors overboard. We miss you ever since you left us. We're stranded in the Nile. David Cooper, Fred Gordin, brothers gone too soon. Our pillars, energizers, we miss you every day.
We pray that your wives and children always be together and strong. The pain you had before ended now, rest in peace. Your vision, goals and roles will always be our daily jobs. We shall never, never let you down. Struggle, luta, continua.
Fred Gordin, David Cooper, super connors overboard. We miss you ever since you left us. We're stranded in the Nile. David Cooper, Fred Gordin, brothers gone too soon. Our pillars, energizers, we miss you every day. Fred Gordin, David Cooper, super connors overboard. We miss you ever since you left us. We're stranded in the Nile. David Cooper, Fred Gordin, brothers gone too soon. Our pillars, energizers, we we miss you every day.
Mama,
Gordin,
Mama,
Cooper, Hannah's overboard. We miss you ever since you left us. We're stranded in the night. Fred Gordin, brother's gone too soon. Our pillars energize us. We miss you every day.
That was a tribute to our heroes, Fred Gordin and David Cooper.
Thank you, Ann. Ooh. We'll now move on to the last part of the sessions this morning. I'd like to call up to the microphone Dr. Princey Kumar from Georgetown, the current Chief Director of our Clinical Core. And Ann and Dana and Jonathan, if you want to come up for the presentation, it's up to you. The academic community of HIV community of Washington, D.C. thought it was important to not just honor Fred, but to do what we know Fred would want to do and pass the torch to the next generation. And so I'm going to give this to Ann, and I'm going to let Dr. Kumar run this.
Dr. Kasai, let me say a few words about Dr. Kasai, and then we'll stay right there.
Okay.
I think anything I'm going to say will be an anticlimax after what the beautiful words that you said and the beautiful message that was said for Dr. Gordon. But behind me, I hear the words that Fred would want us to do is to go on and to be of use. The deep sense of sadness we feel about his loss can only be partly overcome by hearing the message he had for all of us, and which is what you so aptly said, is that we need to continue. We need to continue his legacy, and we need to continue to be of use to the community. So I first want to say how privileged I am today to be able to give this award to Dr. Seble Kasai. And I want to thank you, Dr. Greenberg, Dr. Simon, and the DCCFAR for allowing me the privilege of giving this award. I want to say a few words of who Seble is and why Dr. Fred Gordon would be so proud that she's chosen to be the first person to receive this award. Dr. Kasai got her medical degree from the University of Chicago. She then did her Med-Peds training at Mount Sinai, and then went to Stanford, where she did a fellowship for 7 years. As a dean, I always think if you do a fellowship for 7 years, there must be some remediation somewhere in there. But it's because she did a clinical fellowship, she did a research fellowship, and she got her master's in epidemiology. So she spent 7 years at Stanford, and then actually came to DC because she got married and wanted to spend the rest of her life with her husband here in DC. So she came to DC, and she first started off at the Elizabeth Glaser Foundation. And during this time, again, a debt that I could never repay, Henry Mazur and Dr. Greenberg came to see me one day and said, the vision of DCCFAR is to be able to bring in new investigators, to get investigators. We want to be able to train the next generation of people, and said, we'll give you money. And then I became very excited. And, they said, and then they cautioned it, and then they slipped in the word, a little money. And then, if we give it to you, will you be able to hire somebody or bring into the university somebody that you think can lead us to the next generation of HIV researchers? I was not very happy with the little, so when I went to meet the university, I left the little part of it out. I said, Dr. Mazur and Dr. Greenberg will give us money and I want to hire somebody. And the university, normally they get into very details, but they didn't because they really felt that there was a need. Georgetown University, I'm always proud to say, has always had a commitment to HIV, always had a commitment to disparities of health. So they had the vision and they didn't ask too many details and they said, okay. And I could think of nobody better to bring to our faculty than Sablé Kasai. So we approached her and thankfully she accepted and she came to join our division. She's also started working with Dr. Mary Young, who at that was the PI of the Weiss Grant. And Dr. Young also had the vision to recognize what a researcher Dr. Kasai was. And she felt so confident in Dr. Kasai's abilities that she decided to retire and said, I'm done. Here comes Sablé, I'm done. And she retired. There are very few people who can do it that gracefully. She just got up and said, I'm done. Here, Sablé, here's it. But then Dr. Kasai took it to the next level, and that's what she's all about. She took Weiss to the next level. She went in for recompetition, won, kept the grant at Georgetown. And her area, I'm not going to go into all the areas of research that she has done because she's listening, but her real area of interest is really understanding transmission dynamics and how to decrease HIV transmission. That's why I felt it was so fitting that she's going to get this award. It's a lot of what Dr. Gordin did is how do you take such brilliant research and translate it to help the community. And that's why we were so honored when Dr. Kasai was chosen for this award. In other ways, the DCCFAR, again, I give thanks to the DCCFAR, saw what her brilliance as a researcher. She's not where Dr. Gordin is, but she will get there. But chose her now to become the Associate Director of the Clinical and Population Sciences. So this year she has become the director. The university, Georgetown University, really had the vision also to look at all her research, and the promotions committee also gave her tenure this year. Again, a big achievement for her. But she also had done a lot for the medical school. Very similar to what Dr. Fred Gordin has done. It's really to see how do you not only, clearly they are all brilliant people, but how do you bring up the next generation? And you do it by recognizing people and moving them forward and inspiring them to do better. So she chairs one of the, if this group allows me to say one more thing about her achievements at Georgetown, we have like any medical school, we have lots of committees, but one of our most important committees is the Medical Life Advisory Committee. It's really the committee that says, are students cared for the way they should be cared for so they can reach their full potential? And she is the chair of that committee. And she is a mentor to many students, not just at the school. She's a mentor to many students in the inner city whom the School of Medicine feels has the potential, given the right environment, to be able to get into medical school. And she's a mentor for them. In many ways, she follows in the legacy of Dr. Gordin. And so we are truly, truly honored that you all have chosen to give Sablé, to have Sablé be the first awardee of this Clinical Investigators Award. And I am so grateful. Thank you. I also want to thank you, Jana. I want to thank you, and Jonathan. I want to thank you. Dr. Kasai, can you come forward?
Thank you, everybody. Dr. Greenberg told me it's a really moving moment to be honored in this way, to be recognized, and hopefully I can put myself together to actually give you my presentation. And thank you to Dr. Gordon's family. He was kind to me. When I was first looking, so Dr. Kumar summarized my transition from the West Coast to the DC area. And so her and Dr. Mazur think I did nothing for 3 years but raise a family while I was at Elizabeth Glaser. But it really was, that's when I met Dr. Chasen. It was a really important time period for me that allowed me to really solidify my knowledge, my skills, think nothing else but about research for 3 years. And so it was really a great opportunity, but I didn't have an academic home at that point. And so I was really grateful to Dr. Greenberg and Dr. Mazur for helping Dr. Kumar create a position that allowed me to join the faculty. So my title may be intriguing to some, and I hope it lives up to the title. So really, for me, you know, how I came to learn about HIV, so different than what you heard from Dr. Chason. So I was growing up, I was a young child at this time, but I loved to read. And so I would notice the newspaper or the magazine covers my parents got Time and Newsweek. So I looked at the papers and I'd read about this strange thing. And, you know, it was all quite frightening. And I have to say something about the pioneers who actually entered the field from my perspective. So these are very adventurous people, young, newly out of school, had no one to teach them about this disease. It was scary. People were dying. And yet they were there. And they moved on from whatever else they were studying to say, I'm going to study this disease because what's happening to people isn't right, and we need to find out what's going on. So they really are the virus hunters. You know, like when you see those Hollywood movies, people going to Africa, finding these strange things. I mean, Brad Pitt comes to mind, and they go after trying to figure out how to fix this. That's who you guys are to me in my mind, because really at the time, there was nothing you could do. We didn't know how this was transmitted. You guys didn't know whether you would be affected by this virus by taking care of people. And over a decade later, a little bit more than that, when I was signing to do my residency in New York, I had to sign on a piece of paper that I was willing to take care of patients with HIV. So what you were doing is what a lot of other physicians were not willing to do. And so big tribute. And as you said, you'd had no textbooks to read. Not only that, you had no teachers to teach you. And what we have now as the next generation really is we have lots of things to read, and we have other people's coattails that we can ride on. So it's a huge difference, and we're very grateful for that. And it's difficult as people start to transition out in various ways. And truly, Dr. Gordon and his peers, we greatly appreciate everything that they've done and for allowing us to write the coattails. So here we are, more than 3 decades later. We still have 36.9 million people living with HIV, over half of whom are women. We still have 900,000 deaths every year, so we still have a lot of work to do. But this is the legacy of the pioneers, right? They went, they studied, they figured out what we could do, they found the drugs that we need to treat patients. And so we've gone from HIV, this is US-based data from CDC, being the highest killer of people in 1994, those aged 25 to 44, to now something where we have, you know, a lot of other leading causes of death in that age group. This is absolutely phenomenal, and it's being in the trenches and all the hard work from Dr. Gordon, his peers, that has allowed this to happen. There are still challenges left. You know, there are model data that show if we now start a 20-year-old on antiretroviral therapy, that person should expect to live over 50 years. It's great. The reality is, in 2010, and I apologize, this should be 2010, the average age of a person with HIV at the time of their death was 51. And so we still have a ways to go to really get to where we need to be supporting people living with HIV. So I kind of tried to come up with a, well, big picture, what do we have left to do? And it's interesting for me to hear that Dr. Gordon also liked the big picture questions. Really, big picture, what do we need to do? These are aspirational to some extent. We need a vaccine. Vaccine would be great to prevent new infections from happening. A cure is near miraculous, and we're fortunate in some ways to have seen at least one, maybe two miracles. Treating people with HIV, and beyond just getting medications into people, it's improving their health, improving their quality of life, and there are many components that go into that. The therapy, which I showed you, can be life-saving, is a big part of it. But there are a lot of comorbidities that come along with that. There's a lot of stigma that still exists that makes it hard for people who are living with the virus, and there are a lot of disparities that we still see. And then preventing new cases, this is exciting. So this is actually keeping people who may be at risk from actually becoming infected, and there are very important ways where we can actually do that. We can provide treatment now to people who are at risk, and then there are other additional methods that are also being implemented. I'm not going to be here all day talking to you about all of this, so I have to be brief. So the pinnacle, the cure, right? This is a picture from 2 years ago at Croy, and I was standing at my poster, and for the first time in my life, I acted like a total groupie. Because this man came by my poster, and I was looking at him and saying, I know that face. Who is this person? I know that face. And the person next to me was also, she also kind of was getting this. And, we were in the corner. I think we were in the 600s. Nobody else was coming by. And it was Timothy Brown. And so Timothy Brown is the one person who was cured of HIV over a decade ago, who now is living free of the virus, but unfortunately was near death's door in the process of getting there. So he had a leukemia, was treated with irradiation, total body radiation, chemotherapy, a stem cell transplant, a repeat transplant, but now is AIDS-free, right? So I saw him and I said, wow, I could never see somebody that's, to me, more inspiring, right? And I talked to him and I said, so how does it feel? And I don't know if you'd ever ask that to a movie star because I don't know what they'd say. But I really wanted to know, how does he feel being cured? And he said, it feels very lonely. And it was very striking to me. And when I was reading, we had a second case who's in a long-term remission. So someone who, again, had a lymphoma, was treated with chemotherapy and it failed, unfortunately, had a stem cell transplant, and now is 18 months off antiretroviral therapy and looks like maybe on the path to being declared cured. And I read a newspaper article shortly after this came out, and they had a quote from Mr. Brown that said, "It's nice to have company." So I was looking through, as I was preparing for this talk, I was looking through some data that we've compiled from the women that we follow at WISE. And it was striking to me that 77% of our participants believe that there will be a cure in their lifetime. Really, so I know that there are a lot of naysayers here. So those of us who actually do this work, we are hopeful for the cure. We're not willing to put our patients through what these two individuals have gone through to get there. But the women believe in it. So hopefully we'll get there. It's really important to the community. This is really, I think, one of Dr. Gordon's huge contributions to our field that really put to rest the debate of when should we start people on therapy. It totally put it to rest. There was a lot of debate for over a decade, and this trial really said, start people on medications early. There is a survival benefit, and it's worth the risk. So there are a lot of additional details here. That was the most important thing, because prior to that, even though guidelines committees had recommended treatment for everybody starting from 2012, even the guidelines, and Dr. Powell, who's here in the audience, I read the guidelines because I was like, oh, that's interesting, but some people aren't ready, and what about the toxicities? So there are a lot of reasons to be maybe concerned. And the guidelines said the committee was 50-50% split on the decision, but they were going to recommend it. And I said, well, what kind of recommendation is this? 50-50 split doesn't really help me, but maybe I wasn't supposed to read those details. But this was definitive. So we're not split anymore. Everybody should be treated. And again, this is his legacy. Everybody should be treated. At the same time, we found out a few years before that treating people with HIV not only helps the individual, but also decreases transmission to others. And we don't have a vaccine, we don't have a cure, but this is as close to a magic bullet as we can really get to, because decreasing transmission by 96%, I think, is beyond what our wildest dreams what a vaccine would do. So we went and, Dr. Willoughby, I'm glad that I can show you some data from the cohort you helped dream of many years ago. So this is data from the nationwide WISE, and this is from all of the original sites. And this is close to 2,000 women, and we looked at, well, how have women been doing with getting virally suppressed? We don't provide treatment as part of the study. We just observe, and this reflects the community practices. And so in 1996, which is when combination therapy became available, about 28% of women were virally suppressed. By 2016, it was 84%. So this is really, you can just see a great march up. And when we looked at how many of these women have been consistently suppressed over a 3-year time period, it was actually 71%. And CDC estimates from 2014 are that 47% of people were consistently suppressed. So these women are doing amazingly well. But not everybody is actually doing well. When we homogenize things in this way, we can pat ourselves on the back and say our work is done. But really, there were some subgroups that were not doing as well. And those that we found, there are several things that are amenable to change that could help people do better. Stable housing, depression, and drug use, all things that we can intervene on. And so this is something that we've submitted. It's under review, and we hope will get published soon. But our best laid plans do sometimes have issues that come along with them. And this is data that we, again, show from the cohort, and this is led by my colleagues at Emory. What we found was that the 1 pill once a day combination, a lot of the first line one now includes an integrase inhibitor, which, again, is very forgiving, very well tolerated. But what we found is that there's some subgroup that gains weight with it. And, at first glance, this doesn't seem to be problematic. And it's like, okay, well, you gain 2 kilos, not a big deal. Again, this is homogenized. So we do have, anecdotally, some of our patients who tell you that they've blown up, even though they're eating the same. People who develop unbelievable diabetes in a short span of time, and people who take themselves off the medications because they're on the extreme end of this weight gain. So we still have work to do. We still need new therapies that others who maybe don't tolerate these medications will do well on, and obviously more work to do to figure out, well, exactly who has a problem associated with this medication. And very important for us to figure that out, because this is another colleague of mine, Dr. Mohan Raj, who worked with others in this group in using DC cohort data. Again, this is something that people in this group have come together created. Integrase inhibitor use really is skyrocketing. Again, it's very forgiving, it's very easy to take, well tolerated, but if there are going to be issues with taking this medication, we do need to keep our finger on the pulse and figure it out before we have problems. So, Dr. Kumar mentioned that we successfully recompeted the WISE, and the WISE has now merged with the MAX, which is the longest standing male cohort. So I'm very grateful to Dr. Young and to Lakshmi, who's our project director, really for leaving behind a very well-oiled machine. The DC WISE is extremely well run. Our participants are incredibly loyal. They come regularly to their visits. And when they don't, they take phone calls, and we're able to do phone interviews. And then there are a lot of people who we have been able to engage. Again, this is a lot of Dr. Young's work, and we're continuing to build on that, who take advantage of the data and the samples that we've collected over the 25 years to really do great research. This is the work that we're just doing locally, and does not represent what else is happening nationally. Okay, so we cover very many areas. We're very grateful to the participants. And then we also are training new investigators. So I think some of them might be in the room. Dr. Matt Levy, who's studying cardiovascular disease and the effect of psychological stress on atherosclerosis. Dr. Kate Michelle, who's in my group, who's an immunologist and who's studying the microbiome on disease progression as well as cervical dysplasia. And Dr. Spence, whose picture I was not able to find anywhere on the internet, which I think in itself deserves an award, who is studying the effect of antiretrovirals on neurocognition. And they're all recipients of a DC CFAR award over the last year. And we're really very, I'm very grateful to have the opportunity to work with young, energetic people who are really doing great work. And, you know, I think millennials really get a bad rap, but their creativity is really, when you can focus them and let them loose, is really great. And so I'm really happy to be working with these, with really the next generation, even beyond ours. So preventing new infections. So I'm just, again, you know, our big thing with prevention is there are some fraction of people who don't know their HIV status, and then who we need to test. If they're negative, they really should be given preventive therapies if they are at risk. If they're HIV positive, they need to be treated because, as I told you, the benefit to themselves is huge and the benefit to the public health is also huge. They will not transmit to others. So eventually, we should be able to break the cycle of new transmissions. So I think the tip of the iceberg, can you use the molecular signal of the virus? You know, the virus is, it's a very sneaky virus, obviously, has eluded vaccine for very many years despite the best minds working on this. It changes every time it multiplies, and there are very many copies in any one HIV positive person. Everybody has their own kind of signature virus. We cannot create a different vaccine for everybody, right? So it's been a challenge. There are different ways the vaccine world is trying to handle this. But, you know, our question was, can we use that unique signature to try to understand how transmission is happening? And really the motivation for me particularly here in the district is that the prevalence is very high. So 1.9% of DC residents have HIV, and in some subpopulations this is even higher. So it's over 4% in African Americans, and so it really is still a public health. I don't want to call it an emergency, but it's really something that we need to continue to tackle. And it's a big part of what motivates me. So we decided to look at virus from almost 3,000 individuals from 2014 and 15, and distributed throughout the Mid-Atlantic area. And we said, well, can we find, you know, areas of cases where there was rapid growth of an outbreak or big clusters of infection where we could actually do something. And it was a little bit sobering because though we saw what looked like not significant number of infections that were linked to one another, when we get into the weeds of how closely linked do we want them to be in order to say, to have confidence that they are part of a cluster. If you've heard of the outbreak in Indiana a few years back, when CDC was investigating that, it was very closely related. So it was really the 0.5% difference between viruses that were part of that constellation of that outbreak. And when we look at what we have here, again, this is not a similar, these are not recently infected, these are people with tannin infection. It was a very small number that was going to rise to the top that would have actually warranted investigation. And this is just a different way of depicting that. And so when we looked using a 2% cutoff, we said, let's be more generous. You know, people are chronically infected. Let's see if there are, you know, these big subgroups where we really should be addressing a sub-epidemic. And what we found are 2 groups of 6 and 2 groups of 7, and the rest were pairs, 3s, and a couple of 4s. So it was a little bit sobering for me. If we used the CDC cutoff, there would be 1 group of 4 that would be investigated. And so I think this is a very important tool for our public health colleagues for finding outbreak scenarios. For our long-term work, here it seems as though the virus is, it's just in the community and dispersing slowly and not kind of ballooning or mushrooming into a big outbreak per se. I'm really wedded to that other idea, so it's hard for me to see that, but I'm sure we'll keep working because I know that its utility has to be there. So while we were doing that, and in order to kind of keep populating our sequences, we started this other very small study, and this is something that we did from our clinic, and we recruited 91 people from our clinic who had started coming there from 2013 and onward. And we recruited 91 people. And we said, send us your friends, send us your contacts, anybody you know, just send them in and let's see if we can figure out if they're at risk for HIV or if what we might be able to do. What do we find when you send us in your friends? Send us your friends. So I didn't actually know that anybody would want to do this. But, our patients are very loyal. They signed up for the study. Probably Dr. Kumar told them to just sign on the dotted line. So they signed up. They took a very exhaustive survey about their risk factors and what they do, where they socialize. And they did. They sent in their friends. And I'll tell you, the nurses ran up to me one morning and they said, Dr. Kasai, we have 31 messages. I said, what do you mean you have 31 messages? They had 31 phone calls between 5 p.m. and 9 a.m. the next morning of people wanting to come in for this study. And I said, it's okay, don't panic, just call people, and you can bring them in. This is, they're not being paid to do this. This is just we're doing it as part of our clinic. I said, just give them appointments for when you can. Let me know if you need me to help you, and just see however many. So 31 did not come, but, significant number did. And what I found out eventually was that person who had enrolled into the study that night before had put it out on their Facebook. So I didn't do it. Someone else did it, and people called. So what we found was really fascinating to me. So this is where all of our participants are from. Of the people who were HIV positive, 23% of them were not on treatment. And, we're in Washington, D.C. We have a lot of providers. This shouldn't be happening. And, CDC just recently, this week, released their estimates that they think most new infections are actually being 8 out of 10 new infections are occurring from people who are not on treatment, not what we previously used to think that it was people who didn't know their status, but it's really people who are not in care. So this is fixable, should be fixable, and we should be able to take care of that. The other thing that we found was, of the 49 people who were referred in, 26.5 of them were HIV positive, which was I was quite shocked at that. It's not something I was expecting. And there were a lot of STIs, sexually transmitted infections, both in the positives and in the negatives who we recruited in. And so when we looked at the 35 people who were HIV negative, almost 2/3 of them would have been eligible for PrEP, pre-exposure prophylaxis, simply by having had sexually transmitted infections in the last year or being in a relationship with an HIV positive individual. So my failure in all of this was, we now know this, we are preparing a manuscript, but that's only part of the story. We did not have the resources or protocol to engage these people and actually get them the prevention services that they needed, or to treat those who we found that who were not on treatment. And for me, really, this is where this should go, because that's what's going to lead us to the next thing, where we do have as close to everybody on treatment and as many people as possible who would benefit from prevention being on preventive medications. So this is something, this needs to be replicated. This happening one time. Again, maybe it's just loyal patients, I don't know. Can we do this beyond just our clinic? And then beyond replication, then is can we actually do something effective with this information that we find that's interesting, but it really needs to go to the next level of can it help us decrease new infections from occurring. So again, I want to thank Dr. Kumar for everything she's done for me. She's really helped make Georgetown my academic home. Drs. Greenberg and Mazur, who dreamed up this position. I have many people who helped me work on these projects. So some of the beautiful pictures you saw today of the networks, my research associate Priyanka does those for me. Dr. Zahava Grossman, who again is Dr. Saison, I'm glad you said what you said about forced retirements, but having been forced retired from where she used to run a national lab, we are now working together doing some of these analyses. I'm very grateful to her. And really all of the other people listed here who I could go on, but and then to the family, again, Dr. Gordon and his peers for us are just pioneers, and we're very grateful. Sure. Does
anybody have any questions? Thank you.
Okay, thank you.
So our program is coming to a close. I just wanted to know if anybody had any last things to say. Nope. All right. Well, I'm going to then thank our administrative team for putting together a great event. Thank you to the many members of Fred's family and friends who showed up today. That was incredibly inspiring. And thank you to Dick Chassan for inspiring all of us. And congratulations, Sebely, as you move us forward into the next generation. Thank you. All right. We are adjourned, and thank you all for coming today. You buckle my knees. Thank you for doing it.
Well, thanks for asking.